Hello, everyone. Good morning, good afternoon, or good evening, wherever you are. It is my privilege to welcome all of you to the third day of our Bloodless Medicine and Surgery Week. The week, as we said earlier, is aimed at promoting bloodless medicine and surgery as a very important means of improving clinical outcomes, and in addition, protecting patients' rights, both the patients who decline blood transfusion and those who don't know any better. And this year's theme, as you already heard, is bloodless medicine in maternal and child health, a very important area which many clinicians always wonder about. How possible can we do bloodless care in obstetrics and in pediatrics, neonatology? Fortunately, we have experts in those areas who can shed light on this. My co-moderator will soon join me. Maybe I should delay the introduction till then. I'll just mention that it is an individual who is a household name in patient blood management, bloodless medicine and surgery. That is Sherry Ozawa. We'll be moderating together this morning. So I would like to introduce our first speaker. As I said, it is a matter of puzzlement to many how we can possibly do bloodless care in obstetrics, for instance, and situations where there is a lot of blood loss, like postpartum hemorrhage, which we know is the #1 culprit when it comes to maternal mortality. So how do we do that? Our first speaker is Dr. Prof E I Ekanem, who is a professor of obstetrics and gynecology in University of Calabar and the chief consultant obstetrician and gynecologist in University of Calabar Teaching Hospital in Calabar, Nigeria. He has been head of department, head of examination board at various times, and right now he is the chief consultant in gynecology oncology unit as well of the University of Calabar Teaching Hospital. He heads the Committee on Prevention of Postpartum Hemorrhage, so he's in a very good position to talk on this subject. Currently, he is the chairman of the University of Calabar Teaching Hospital Patient Blood Management Committee and the Departmental COVID-19 Incident Management Committee. He has presented several papers in several international and national local conferences, mostly in the area of obstetric hemorrhage and infection prevention. He has published over 60 papers in peer-reviewed journals and has written books on obstetrics and gynecological practice in the tropics, infection prevention and control in hospital setting. And of course, he's an editor of some national as well as international medical journals. Very significantly, Professor Prof E I Ekanem is a founding member of the Bloodless Medicine and Surgery Group in University of Calabar Teaching Hospital, as well as a founding member of the Bloodless Medicine and Surgery Society, from which society he has received an award of excellence for his excellent contributions to the science and practice of bloodless medicine and surgery. That was in 2015. Of course, he is a member of several other professional societies. So without further ado, I'm going to invite Professor Prof E I Ekanem, and he's going to talk on the topic, managing obstetric hemorrhage without blood transfusion. Dr. Ekanem, please.
Good afternoon, good morning, good night, everybody. Thank you very much, Nathaniel, for that elaborate introduction. I'm grateful for it. Let me start by thanking the organizers, the Bloodless Medicine and Bloodless Medicine and Surgery Society, for inviting me to discuss on management of obstetric hemorrhage without blood transfusion, which I think is also regarded as bloodless management of obstetric hemorrhage. It is nice to be here to discuss something that is very dear to me. Let me say that I don't have anything to disclose because there's no interest. I'm working in the University of Calabar Teaching Hospital as shown on the screen there. This is where all the activities that I have done so far that has been undertaken. It is a tertiary institution with multidisciplinary units, which is essential for management of obstetric hemorrhage in a bloodless manner. Then I'm going to discuss this on the following outline: introduction, our own experience, the concepts of obstetric hemorrhage, and others. By way of introduction, obstetric hemorrhage is a leading cause of maternal death and morbidity worldwide. And you recall that obstetric is a bloody condition. When hemorrhage is added to it, it becomes devastating. So it is a miracle and somehow something that we need to do so that mortality will not be accentuated in a woman that has obstetric hemorrhage. The incidence is more in the developing countries of the world and account for about 30%, a third of direct cause of maternal mortality. Like I said, the prevalence in the developing world is almost half of what is obtained in most developed countries. And it is highly preventable. The maternal death from obstetric hemorrhage is highly preventable using the available technology in a timely manner and an effective way. So it is something that we know that us as practitioners, we have to be involved to avert this calamity, because both the incidence, mortality associated with this condition can be prevented. It's also associated with severe maternal morbidity. It is noted that a woman that bleeds, apart from the immediate problem that it has, there's also a remote and long-term complication that these women have, such as renal problem, residual anemia, which sometimes, mostly in our developing countries, may be devastating, may be even difficult to control. And so it's better to institute basic and effective management in these women to avert this severe maternal morbidity. The figure on the screen there shows the morbidity associated with severe obstetric hemorrhage. If hemorrhage is so high in such a way that blood is transfused, the level of morbidity is higher. And between 1993 to 2014, it tends to go higher in this study that was conducted in the United States. And you can see the green color there showing that women who were not transfused, the morbidity were low. And then what is bloodless medicine, as it were? This had been discussed since on Monday. But essentially, it is a situation that we use a comprehensive and multiple approach to manage patient to the extent of avoiding allogenic blood transfusion and also improve patient outcome. Global definition is that patient-centered, systematic, evidence-based approach to improve outcome by managing and preserving patient own blood and promoting safety and empowerment. Essentially what this means is that if a patient is managed without blood transfusion, it's likely that the outcomes will be better and the patient's condition will also improve more than those that have been transfused. So these are the pillars of bloodless surgery. This has also been elaborated in previous presentation by the presenters of yesterday. The first one is optimizing the hematocrit. And essentially this will help to the patient to tolerate blood loss. And this is done by using ion therapy and other form of medical therapy to improve the hematocrit of this patient within a short period, so that even if the woman is bleeding, the blood loss can be tolerated. There are so many other ways that this can be done. Then the second pillar is minimizing blood loss. Using clinical assessment for bleeding, pharmacological agent, intraoperative procedures, this can actually be accomplished with most of our patients getting the best treatment that they want. So it's usually good to combine all these methods of pillars of bloodless surgery for us to get the optimal outcome. Then optimizing tissue oxygenation is replacement of the volume that has been lost, oxygen therapy, and reducing consumption of oxygen. This has been done in various ways, which I will not want to elaborate here because it had been discussed at previous presentation. But suffice to say that this will help the result of management to be such that the outcome becomes better than those that blood have been transfused. Why do we need to bother ourselves about blood conservation? First, which is what we know all over, is to avoid risk of blood transfusion, infections, immune modulation, and others. But more importantly, in our setting, cost become a very important factor to institute conservative management. Cost is not only the cost of procuring blood, but to make it safe, storage, and other socio-cultural factors. Because in most developing countries, culture and other social conditions will influence the procurement of this blood. Sometimes it may be linked to certain cultural condition that is available in that environment. Then availability of blood. This is usually very critical because these days donors are not found. Storage facilities are scarce. Screening protocols are limited, particularly in most resource-constrained environment. And because of this, it's better to avoid the use of blood. As has been discussed since Monday, it is good clinical practice for you to consider conservative blood management because it has been shown to give a better outcome than when blood is administered. And in my center, patients that have been sent for bloodless management get the best treatment from all the medical practitioners because many people put up the best to avoid the complication that can occur without the patient getting blood. So because of that, most of the patients have better and more satisfactory management from the society. So it's not only that the blood is not available, there are so many other conditions that will make us to consider the use of blood, the avoidance of blood in these patients. Now let's look at the blood concept of obstetric hemorrhage. The major and the most fundamental problem with obstetric hemorrhage is lack of unified definition. Many settings define obstetric hemorrhage differently, and because of that, it's difficult most time to compare research and to compare notes. And sometimes patient management may suffer, because while some would think of 1,000 meals as a cutoff point, others talk of 500 meals as a cutoff, or 1,500 meals as a cutoff point. Royal College of Obstetricians and Gynecologists define obstetric hemorrhage as blood loss of 500 to 1,000 meals, and severe obstetric hemorrhage as blood loss greater than 1,000 meals, or blood loss of 500 to 100 meals with clinical sign of hypovolemic shock. Because sometimes you may not need to have the quantity of blood to be so much before you define it as severe hemorrhage. For example, women with who were anemic before coming to the hospital, and those who were sick with other form of comorbid condition, which small amount of blood that is lost could tip the patient into cardiovascular instability. World Health Organization defined it as loss greater than 500 mils, severe hemorrhage greater than 1,000 mils. But let's see what others are thinking about. The problem with the obstetric hemorrhage assessment is that clinicians generally underestimate blood loss, sometimes by half. And especially if the blood loss is much, the more the blood loss, the more the estimation is the more the underestimation of blood. And the other important factor to consider is that average blood loss during vaginal delivery is about 500 mils, and cesarean section about 1,000 mils, which almost approximate the definitions of both. Because there are some that define obstetric hemorrhage as vaginal delivery of 500 mils and cesarean section of 1,000 mils. And when you consider this, it means most of these patients may not even be classified as having obstetric hemorrhage. And the physiological adaptation of pregnant women allow blood loss to be tolerated to the extent that a woman can lose up to 1,500 mils before any significant change can be noticed in blood pressure and heart rate. And that means it should be vigilance, not necessarily waiting for the changes that occur in the cardiovascular system of these women before intervention is done. That is why a protocol and a systematic way of making a diagnosis and managing this patient is critical to making early diagnosis, like we will see later in the discussion. One of the challenges we have is not getting the patient for treatment early enough. Laboratory evaluation is generally too slow to be meaningful, and it does not reflect the dynamic condition that occurs in a woman that is bleeding during obstetric hemorrhage. So relying on laboratory investigations to manage this patient may be misleading, because by the time the laboratory result comes, the condition at that time may actually be different from what the laboratory result will give. And this brings a very serious challenge. And that is why most management setting, even though the laboratory result is rely on for certain other conditions, but it may not help you in the acute and immediate management of this patient. So it's also considered that these women will be better managed using the clinical parameters, as it were. Having discussed this, the woman that will have increased risk of obstetric severe outcome, bad outcome from obstetric hemorrhage is a woman that has greater than 100 mils within of blood loss within 24 hours following birth and continue despite use of initial measures, including the first-line uterotonic drugs and massage. So sometimes the bleeding may not be that you have in postpartum hemorrhage, that is pouring and in large quantity at a time. It could be trickles over time. And these are the ones that usually being overlooked. For example, a woman who had a episiotomy that is bleeding, not torrential, maybe just changing parts, over 24 hours, may lose more than 1,000 mils. So a continuous bleeding in that form is also considered as a very important cause of morbidity following obstetric hemorrhage. Now, the table here shows some of the changes that you may need to observe before, when a woman is bleeding. And this table actually explains what I had been discussing, that sometimes pregnant women tolerate hemorrhage in such a way that before the clinical condition changes, it's likely that a certain amount of blood must have been lost. For example, if a woman lost 1,000 mils of blood, the systolic blood pressure is still greater than 100. The heart rate is less than 100. She may just have lightheadedness or palpitation. She may need to lose up to 1,500 mils for the systolic blood pressure to change between 90 to 100 millimeters of mercury, and heart rate of 100 to 120. They just have weakness and sometimes dizziness. She may need to lose up to 200 mils before you have significant change in the cardiovascular system. For example, 3,000 mils need to be lost before the woman is panting for air. These guys try to assess using systematic review of relationship between blood loss and clinical signs to see how this can be used in clinical practice. Their conclusion is that even though there are variations in the clinical findings and the blood loss, the clinical signs and the blood loss, the sign of shock is the most reliable of all to assess the amount of blood these women lost. So by the time that you wait for the shock to occur, that means the woman would have lost up to 2,000 mils to 2,500 mils. So this study has actually highlighted the point that it is not feasible for us to wait for the woman to get to shock level before we know that the blood loss had been significant. Let's see type of peripartum hemorrhage. Obstetric hemorrhage is also regarded as peripartum hemorrhage, usually classified based on the timing of delivery. Antepartum, placenta previa, uterine rupture, placenta abruption, and others. Postpartum, uterine atony, placental factors, genital trauma. the commonest of all obstetric hemorrhage is postpartum hemorrhage. Not only that, the prevalence and incidence is high, the mortality is also high in postpartum hemorrhage because it occurs suddenly and in large quantity, sometimes overwhelm the system, both the personnel and the facility that are available. So it is important most times when protocols are being developed, most protocols will center on the management of postpartum hemorrhage because it's the commonest cause of obstetric hemorrhage. Coagulation disorders, both acquired and congenital, are also available as cause of obstetric hemorrhage. Management of obstetric hemorrhage is centered on the cause, resuscitating the patient, looking for the cause, and then tailor the management to individual pathology. This is very important. Let's see factors that we can use to predict a woman that will have obstetric hemorrhage. Even though prediction does not correlate with the incidence of obstetric hemorrhage. Most obstetric hemorrhage will occur without any risk factors. But the risk factors will help us to plan and have a strategic arrangement for treating this kind of patient. Because if those with risk factors are overlooked, they are more likely to have severe hemorrhage and the outcome that is more disastrous than those who just developed. So, person who had previous postpartum hemorrhage or obstetric hemorrhage like antepartum hemorrhage, postpartum hemorrhage, is likely to be exposed to having another hemorrhage. Anticoagulant during that pregnancy, exposure to it, gestational anemia. I had mentioned anemia in my introduction. Anemia is such that irrespective of the amount of bleed that the lady has, may tip her into cardiovascular instability, severe preeclampsia, uterine leiomyoma, uterine fibroid. Like the case that we had managed in this center, who had uterine atony, it was because of uterine fibroid in pregnancy. We are going to discuss this in detail as we are progressing. Multiple gestation because of overdistension. Then intrapartum causes prolonged duration of labor greater than this, operative delivery, and placental factors. Placental factors range from retained placenta, morbidly adherent placenta, and other form of placental abnormalities. This will predispose a patient to having obstetric hemorrhage. So a patient that will have this, it is usually good to screen. There are so many other factors which I have not brought in here. If you look at, I said, factor associated with severe obstetric hemorrhage, there are certain factors that will cause overdistension of the uterus that will predispose to uterine atony that I have not brought in here. But this has been studied to show that women with these factors are more likely to get severe obstetric hemorrhage. And these are the ones that plans must be met in a setting. If it is in a setting that facilities are not there to tackle, should be transferred to centers that can handle that. Now, this is a classification of obstetric hemorrhage, class 1, 2, 3, and 4. It is the blood loss that is the paramount parameter here, factor, to use in assessing the severity of obstetric hemorrhage. But you can see other parameters there, like the blood pressure, hypotension, capillary refill, respiratory rate, urinary output, then others like dizziness and shock. These are factors that, as you are taking your history, clinical evaluation of this patient, you have to note this so that you'll be able to classify the woman, whether she's in class 1, class 2, class 3, or class 4, because management is tailored to each class. For example, if a woman is in class 1, it's likely that the aggressiveness and all the armamentarium of treatment may not be deployed to treat this patient, and those facilities may be free for other people to be attended to, compared to a woman who is in class 4. Class 4 may, in some places that blood may be transfused, is what they use a large volume of blood, up to 20 pints of blood to transfuse to get that out. Whereas a woman that is class 2, moderate management of certain factors can tip the woman into good outcome. So it is always important that while managing obstetric hemorrhage, this classification, as you can see here, this classification is clinical. It is not something that needs high bulletin gadgets, electronic and all that. It's just for a clinical assessment, which means it can be used in remote places. It can be used in high places, in quote, as it were, to manage these cases. So this is
I think our professor froze. Are you seeing him frozen?
Yeah, it looks like his connection dropped out. Let's
Okay.
see if he'll come back in a moment.
Okay.
It might be up to you if you want to wait or continue on. I think he just lost his connection. He'll be logging back in.
We'll give him a moment to do that. While he's doing that, are we having a technical issue perhaps with our Q&A, Yvette? It's not entering into the Q&A? You're muted, Yvette. You're muted.
I couldn't get it in mine.
I'm sorry, it looks like Professor Ekanem lost connection, but we're trying to rectify it.
Yeah, while we're doing that, Nat, we're just checking on a technical issue with the Q&A.
I had the same problem yesterday. I could go on the chat, but as a panelist, I couldn't come in and put anything in the Q&A.
Yeah, that's correct. I believe the Q&A is just used for attendees and panelists can answer questions on it. But if a panelist has questions, they need to raise their hand and ask or put it in the chat.
All right. Thank you. Thank you, Natalie.
Thank you.
Yeah. Sherry, really quickly, if I could just make a comment as Professor comes back in. I am loving what he's saying, and many of the other speakers in the last couple of days have said this, and it may seem silly in a way, but everyone is talking about looking at your patient. We're really talking about that art of medicine where you are at the bedside, you're watching the reactions of these patients, you understand their underlying diseases. And he just made that point. You don't have to have some fancy computer. You don't have to have a lot of, even some laboratories, which of course as a laboratorian I think are important. But I really love that everyone is talking about those basics of getting back to bread and butter patient care. And let's watch what's happening with our patient. Look at those trends and we'll see those things start to happen. So bedside vigilance, I think, is very, very important. So I love that the speakers are bringing that out.
Yeah, I'd agree. Yvette, did you want to say something?
Yes, can you hear me?
Yep, I can hear you.
There's a lot of emphasis right now on personalized medicine. And so everything that he's saying fits right into that. And as you're saying, Dr. Burns, getting back to looking at the patient. As a medic, that was the first thing that we were taught, and somehow it kind of got lost through the years.
Thank you. I think good points. I'm not seeing our professor connecting. Anybody?
He said he's back, but let me see.
Okay, while we're waiting, Jamila, are you on? I know you had a comment as well. I see your name, but maybe you can't hear us. Okay, we'll get back to Jamila. So what do you think, Nathaniel? Should we move on to Dr. Mazin and come back to our professor? Oh, there's Jamila. Hey, Jamila. Did you want to say?
Hi.
Hey.
Yeah. Sorry, I'm not. Yeah. Hi. Good talk. I came in the middle, so I don't have a question at the moment.
Okay.
Mm-hmm.
No problem. I thought Matt mentioned that you wanted to, so that's okay. All right. So I guess while we work on our technical challenges, I think we'll move forward and hopefully Professor can join us when he makes it back and finish up his talk and hopefully be here for the Q&A. So if we have no other objections to doing that. Oh, I think he will be back. Hold on. That is back. I see his name popping up.
So he wants to know where you head up to, which was the last slide you got.
He was mentioning to, I think his last key point, as Carolyn said, was mentioning to us that even in areas where there's not a lot of higher technical or equipment capabilities, patient evaluation is the most key. So he had that slide with the different levels of hemorrhage. We saw this. Yep.
That's it.
Yeah. Okay, so Professor, we can't, oh, maybe your sound is coming on. We can't hear you. There you are. Okay.
Yeah, Sherry, can I ask a question? I mean, I know we just got fibrinogen concentrate in our hospital and we have not used it, So do you have any experience using fibrinogen? I know it's not in the talk, but do you have any experience using fibrinogen concentrate in obstetric hemorrhage?
And so, I would say, or maybe that's for the professor. Did you want, was that directed to Professor Ekanem?
Yes. Well, in our center, we normally use it when we know that when the result of the test we do show that the major problem that the woman has is not the packed cell. Then we use that to correct some of but in our unit, we don't normally use it because it's not even available. We don't have the separation of the blood component in our center, but from literature, it is very important because that will avoid a large volume of blood being transfused to the patient, but we don't have it in our center.
So we must apologize for that break in transmission. It's partially my fault. I think, Dr. Ekanem, you can finish your presentation and then elaborate more on what you were saying.
Okay. I think this is where I was, that we need intra-professional approach. I don't know whether you heard up to that point, in order to have a better maternal and fetal outcome.
Sherry, was that the point?
Yeah, I believe we're at this point. Yeah.
Okay.
Okay. That we also need coordinated responses and well-developed contingent plan and protocols for managing massive hemorrhage as imperative to reducing mortality associated with obstetric hemorrhage. Each unit that is vested with the management of obstetric hemorrhage must have a planned protocol, a planned way of attending to patients from the diagnosis to what is done step by step that we have in our center. We are going to discuss this as we progress in this discussion, that it is imperative that a well-coordinated plan and protocols that are communicated to personnel that are involved in this management from time to time, and drills, so that if crisis occur, it's not the time that people are trying to find out what to do at any point. It is something that is coordinated, well planned in a coordinated manner. Then the basic management include monitoring the signs and symptoms of hemorrhage, managing the bleeding, maintaining tissue oxygenation and perfusion, monitor for coagulopathy and its complication. The first point of management is preventive. Preventive management is imperative because waiting for obstetric hemorrhage to occur before treatment is instituted, most likely that facility will be overwhelmed. That is why WHO brought out the form of management that is instituted particularly to prevent postpartum hemorrhage, which is active management of third stage of labor. This has been evaluated all over, both regional, sub-regional, local, and found out that it has worked to prevent obstetric hemorrhage, particularly postpartum hemorrhage. And it involves using oxytocin administered intramuscularly at the delivery of the anterior shoulder or of the baby. It is given to all women, all pasturant, irrespective of parity, irrespective of gestation. It is imperative that this active management of third stage of labor is instituted to prevent obstetric hemorrhage. The use of intravenous oxytocin, 20 to 40 international units per mil, that is about 150 mils per hour, is acceptable as alternative to the use of oxytocin intramuscularly. Then an IV bolus of oxytocin can also be given 5 to 10 international units slow over 2 minutes, particularly during cesarean section. And it can also be given during vaginal delivery, but mostly during cesarean section. The classification here is 2B, which means it has been evaluated to show that it is something that is desirable for us to. And then delay clamping of cord, the umbilical cord, is also part and parcel of AMTSL. Clamping of cord is a controversial matter, but delay or not delay clamping of cord is very important. It is necessary that cord is clamped at a particular time to allow certain the blood to flow to the baby and also prevent certain complication in the baby. There's no evidence that in an uncomplicated delivery without bleeding, the accelerated delivery of placenta, this is very important, placenta can prevent risk of postpartum hemorrhage. So delaying delivery of placenta within the 30 and 45 minutes can be allowed because uterine contraction and others will occur during that period so that delivery can be effected to prevent hemorrhage. The delivery of the placenta can be done using control contraction. This figure, I got it from my participation in the workshop that had been done recently in an issue in obstetric ultrasound scan. Why I got this is that it has displayed most of the drugs that we use in management of third stage of labor in form of prevention. In fact, essentially all the drugs here are used in this management. Oxytocin, like we mentioned, is the key, both in prevention and treatment of obstetric hemorrhage. The oxytocin is given either IM or IV. But the problem with the oxytocin that we have in this part of the world, in the tropic, is that it is heat labor, which means it needs certain refrigeration and other factors to keep it potent. Recently, people have questioned the integrity of the type of oxytocin we are using in this our side because of this issue of not having the appropriate temperature to get it to the point that administration will give the potency that we need. Recently, development of heat-resistant oxytocin had been muted, and in some places they are available to use in obstetric management. We can also use a combination of oxytocin and misoprostol in the form of treatment, not prevention this time around, form of treatment. Misoprostol, we know, is active in contracting the uterus in a sustained manner. And when combined with oxytocin, the duration of action tends to be higher. But the problem with misoprostol is that there are certain patients that it may not be very desirable, very necessary for us to use because of comorbid condition. For example, a woman that has an asthmatic attack or other respiratory factors, problems. So those ones may not be used. Cytometrin is also there. It's a potent, it contracts the uterus in a sustained manner. It's a combination of syntocinon and ergometry. It is desirable too, particularly if there is intractable uterine bleeding. It is good to avoid in women that have predisposition to hypertension because this will accelerate that condition. Carbamazepine is currently being considered as a replacement to oxytocin because it is more heat stable. Even though the onset of action is a little delayed, but the duration of action is higher than oxytocin. In some places, it is used as oxytocin is used, even in the preventive level. But most time in cesarean section, it is desirable to use this because it will cause a sustained contraction of the uterus over time. There are other drugs that are very important in contracting the uterus, one of the uterotonics, that can be used to help us manage this patient to have a desirable result. I also got this from there, that there are certain research that is going on, a multi-center research that involve developed and developing countries and some in Nigeria because of treatment challenges, delayed or inconsistent use of intervention for postpartum hemorrhage. And this tends to be the solution. Because the major thing is that, like I mentioned during my introduction, that there is differences in diagnosis, differences in definition, differences in mode of management. This uncoordinated way of treating obstetric hemorrhage leads to delay in the treatment of this patient. So this method of having a bundle of treating this patient was developed in terms of study. If we consider, the first one is the uterine massage, the use of oxytocin drugs, the use of tranexamic acid, IV fluids, and others, down to when surgical intervention will be instituted. When the result of this will be available for us to use in practice, I hope it will help us to overcome some of the challenges that militate against having effective treatment of this. Tranexamic acid had been used for treatment of obstetric hemorrhage recently. Until recent, it was used in trauma cases and other bleeding, management of other trauma. But the crash study too demonstrates that tranexamic acid reduces the risk of death from bleeding from trauma patients. And the recent woman study in obstetric and gynecology has shown that it is safe in the treatment for obstetric hemorrhage, both in vaginal delivery and elective cesarean section. So it is now effectively used in obstetric and gynecology to prevent obstetric hemorrhage. It is an antifibrinolytic agent, which mainly tranexamic acid is one of them. The more efficient approach could be to administer tranexamic acid after onset of postpartum hemorrhage. This is what the study had shown. But recently, tranexamic acid is now used as prophylaxis, particularly in women who have predisposing factors to this. The medical management includes using those ones. The surgical management approach that we need to use in obstetric hemorrhage. This includes manual compression of the uterus, packing of the uterus, use of balloon, compression sutures, repair of laceration and genital tract, manual removal of placentas, and others. But let me say that there are so many points that we have to use to prevent, to have good results when we are treating obstetric hemorrhage. Preoperative assessment and workup and planning. Intraoperative surgical, anesthetic, technological, and pharmacological agent. Postoperative care of this patient. This is essentially the pillars of bloodless medicine. Surgical approach is the use of careful planning of surgery, patient positioning, meticulous surgical technique, and careful hemostasis, mechanical occlusion of blood vessels and local constriction agent used to prevent the excessive hemorrhage. Well, there are so many compression sutures, particularly in postpartum hemorrhage. This is a B-Lynch method of doing compression suture to prevent uterine, to treat uterine atony, to prevent severe obstetric hemorrhage due to postpartum hemorrhage. This is another one. And multiple sutures, uterine artery ligation is also there. And uterine artery ligation is done when other form of conservative and surgery fail. So uterine artery ligation may be done in a stepwise manner. Result had been there. Then peripartum hysterectomy is also one of the major point treatment that can be used in the treatment of obstetric hemorrhage. For example, most women that have high morbidity, mortality associated with postpartum hemorrhage is when there is a delay in giving a definitive treatment like hysterectomy. And that is why I say here, it is sooner to do hysterectomy than later. And it needs to be performed rapidly. These are some of the other forms. Then intraoperative salvage. This had been done over the years in other disciplines. It was really being done in obstetric practice because of fear of the transmission of infection, transmission of fetal skin and squams, and amniotic fluid embolism. But with the introduction of the filter now that are available, it is now being used effectively. Cell salvage system can provide about 200 ml unit of blood with hematocrit of within 3 minutes. And with this filter, the fear of embolism and other transmission of fetal squams have been reduced to almost minimum. There are so many methods of doing this, but it is in our environment, it's very expensive for us to do. In some remote centers during ectopic pregnancy, rupture ectopic pregnancy with massive blood loss, the scoop, filter, and transfuse have been done, and with varying results. But with sophisticated machine like the one I'm showing here, it's likely that there will be a closed circuit management of this, which could be acceptable to most people that would not want to have this due to religious belief. Now, this is the protocol that we have in our center. The protocol of management of PPH that we have in University of Calabar Teaching Hospital that has given us the result, the remarkable result that we have. When this protocol is instituted, we hardly run into a woman that will not, we hardly will come to high morbidity as been enunciated earlier. So most patients using this protocol will go home well, and the result is usually very satisfactory. The protocol includes that it is a multidisciplinary group that is put in this area so that you involve the hematologist, the pediatrician, the obstetrician, and others, including the nurses, so that a coordinated factor will be used to manage this patient. The first one is that screening at antenatal care for predisposing factors and previous history, patient identified, will be given special attention. Jehovah's Witnesses are given special attention because some of them will provide the hospital with power of attorney. And because of this, they are treated as special group of patients because of them not desiring blood transfusion. Early hemogram using the point of care is also important. Once a diagnosis is met, this team is activated and all the protocol that has been set here will be instituted to achieve good result. Oxygen is optimized. If necessary, IV ion and erythropoietin is given. The fluid management is as set up there. We have colloids as well as crystalloid. Tranexamic acid and vitamin K is given early, either as prophylactic or as treatment. Intravenous iron and erythropoietin is given when necessary to increase the production of hemoglobin, as it were, the packed cell volume, and others. Now, we also have what we call PPH team. This one is different from the main protocol because the main protocol, whether there is PPH or the group is invited in other areas, is instituted. But in PPH, this team is directly involved in managing PPH with an alarm. Sometimes it could be the ward assistant that instigates this. You may not need to wait for a nurse or a doctor to start the process of treating this patient. There's an alarm that once that alarm is sounded, then the team is activated and the necessary action is taken. In women that, let's see this. Then protocol for women who has vaginal delivery. We institute AMTSL. We ensure IV fluid is given, intravenous access is given. Sometimes we give two on two hands using size 16 gauge of intravenous cannula. Pulse oximetry is done to check the oxygen tension. We maintain pneumothemia. Pneumothemia, we know that if it is not well managed, it's likely to cause more consumption of oxygen. Then the other management includes the one we put up there. Now, the UCTH experience. There is a bloodless management of severe obstetric hemorrhage with very severe anemia, a case report by Dr. Osara recently. And this is a landmark case because this woman was a 32-year-old para-zero with twin pregnancy and uterine fibroid who expelled the baby at 23 weeks. After expulsion, she had PPH, which resulted in exploratory laparotomy at HB of 3.3 grams per DL. A total abdominal hysterectomy was undertaken because there was uncontrollable hemorrhage, and the HB reduced to 1.8 grams DL. She received about 4,500 mL of fluid within 24 hours. And this tipped the woman into fluid imbalance and fluid and electrolyte imbalance with HB of 1.3 grams per DL. She had seizures, hypochloremia as stated there, but it was effectively managed with oxygen and other therapy that on the 6th day, the electrolyte was corrected and the packed cell volume, the HB returned to 2.7 grams per DL. On 8th day, she was discharged from the ICU and she was subsequently managed. This is the case of a woman that was on book, 24-year-old para-zero lady in advanced neglected obstructed labor. She came from what we see there, obstructed labor. She attempted to deliver in TBA. We managed with emergency cesarean section using the protocol I have highlighted. The mother and child were alive and with no complication. Another one is this woman who had also a book lady that delivered in peripheral medical facility with acute uterine invasion and placenta accreta. She had a PCV of 20%. She refused blood. She was successfully managed in the hospital using the well-established BMSG protocol. This woman actually was so bad that to even remove the placenta from what you see, it took us a day or two before we can institute that because she was very unstable. She was able to tolerate anesthesia for us to reduce the uterus. The challenges we have is attitude of our people that still resist the use of bloodless medicine to manage cases, but the attitude has changed so much in recent times that we believe that most people are now embracing the use of bloodless medicine in the treatment. Institution, equipment, and support are what we need to do what more than what we are planning to do. Now, other factors is that it now becomes a global practice. We said that training curricula should be changed, both medical and basic medical and applied, and also at the postgraduate level to reflect this, because if it is not reflected, it is difficult for people to follow at this level, even at postgraduate level. Research, there's a research that is ongoing, the study of outcome of blood transfusion alternative in women undergoing major elective gynecological and obstetric surgery operation in the University of Calabar Teaching Hospital. It's a comparative study. Those who refuse blood transfusion and those that blood transfusion is accepted. So we compared the two. The preliminary result is very encouraging. Then collaboration with other institutions may be what we need. In summary, what I have tried to say is that most children who experience significant bleeding have no recognizable risk factor. So all patients that comes to us should be screened for possible OH so that acute and accurate management should be instituted. It will be instituted. Given the instability to reliable predict patient at risk for obstetric hemorrhage, all parents should be considered to be susceptible. Extreme vigilance must be exercised in the assessment of blood loss, hemodynamic instability during peripartum period. Obstetric-specific hemorrhage protocol, facilitating the integration and timely escalation of pharmacological, radiological, and surgical intervention are critical to successful management of peripartum hemorrhage. Thank you very much for listening.
Thank you very much, Professor Ekanem, for that very illuminating lecture. I had introduced Sherry in her absence, and she's now here live. So I hand over to Sherry, please.
Okay, thank you, Nat. And again, I apologize everyone for a slight conflict earlier. So thank you, Dr. Ekanem, and we'll take questions and answers that right after Dr. Mazin's presentation. Yeah, okay. All right, so thank you again for your presentation. I'm glad we got you reconnected. We now have the pleasure of having with us Dr. Howard Mazin, my friend and colleague. He is the Associate Chief of Pediatrics and Newborn Medicine at Englewood Health. He's board certified in pediatrics and neonatal perinatal medicine. He specializes in treating newborns, particularly those born prematurely. He received his MD from the New York Medical College, did his internship in pediatrics at Schneider Children's Hospital, and a fellowship in neonatal perinatal medicine at Mount Sinai Kravis Children's Hospital. His areas of special interest are neonatal protocols, neonatal nutrition, and bloodless medicine. He is a member of the American Academy of Pediatrics, the American Academy of Pediatrics section on perinatal medicine. Dr. Mazin has lectured and presented his work on fetal and neonatal conditions and diseases at various conferences and conventions, now including this one. I've had the pleasure of working with Howard for many years, has done an exceptional job, very modestly, on so many patients, kids and babies whose families for whom transfusion was not an option, and does an excellent job. And Howard, so happy to have you here today. Look forward to your lecture.
Thank you very much. I'm going to try and see if I can get this to work here. Okay. I think. All right, I think I've got it. Thank you very much, Sherry, for that very nice introduction. I also, for those following along on video, even though it's 2 years in, I really haven't mastered the backlighting of Zoom or making my picture look exactly as great as well as I could, but please bear with me. So my talk this morning about managing neonatal anemia without transfusion, definitely an emerging topic and one of critical importance. I have no financial interest or conflicts to disclose, and I really won't be talking about anything off-label or out of approval during this talk. So my goals and objectives for this morning, I think when we look at neonatal anemia and the issues that take place right after birth, I think I break it down into 3 parts. One is, how do we get here? How do we get to having babies who have anemia? I know many of them are physiological. We'll go through the causes. And then once you are anemic, is like, how do we get back? How do we, instead of getting lost, instead of how do we, once they are anemic, what can we do? And what can we provide for our patients and the babies in our NICUs to go from being anemic to having a normal red blood cell count and hemoglobin? And more importantly, that's where the traffic management comes up, is how do we not get lost the next time? How do we take babies who we know are potential to be anemic, and really that includes all babies given their physiologic changes, but more importantly, our preterm babies, our other babies at risk, how do we not get lost next time? What can we do right after birth in our treatment plans, in our treatment protocols, to make sure that patients do not get to a point? Because, and this will come back to you throughout the talk, unfortunately, there are certain levels of anemia where we know we can allow babies to fall to, because we know that there are going to be severe neurodevelopmental outcomes. And that's always the key point here. It's not particularly what happens in the moment for that baby. It's what do they look like, as I tell parents all the time, 2 months, 2 years, 20 years down the road. So we're going to go through some of these different parts and see where we are right now in our practices. So neonatal anemia. So the first question we always have to say is, what is it? How do we define it? It's definitely different than in adults. I'm not sure how many people are pediatricians or neonatologists or work in neonatal units on this talk, but clearly, obviously, we all know it's a low number of red blood cells in circulation. And at birth, right after birth, for term infants, we're talking about 14 to 24 grams per deciliter. In preterm infants, it's slightly lower, and obviously this will depend on gestational age, and we will go through that, but 12 to 20 grams per deciliter. But that's the textbook definition. All of our patients do not read textbooks. And many are lower, given the cause of their premature. It could be maternal issues such as sepsis or preeclampsia, and there could definitely be issues intrinsic to the baby themselves, and we'll talk about those in a few moments. So when we talk about anemia in neonates, we're talking about the first 1 to 2 months of life. The official definition of a neonate is 28 days, but I think if we look at it, especially for our preterm patients, of being 1 to 2 months of life, that's a good way that there's definitely physiological changes after that kind of put them into more of the infant and toddler category. A significant, as we mentioned, a significant drop in circulating red blood cells and hemoglobin, and culminates in what we call the physiological nadir. In term infants, you're talking about 10 to 11 grams per deciliter. Preterm, again, slightly lower, 9.5 grams per deciliter. And that is when we talk about physiologic, that is how the body is designed to work. and how the baby is actually designed to go through the processes from fetal life to extrauterine life. So why does this happen? Why do we have a physiologic nadir? We have what we call, like I said, physiologic. There's anemia of prematurity, which is just a decreased production and a slower production in our preterm infants. And overall, the red blood cells in a newborn, the lifespan is lower. It's only about 60 to 90 days, which puts you into that 1 to 2 month period for seeing a physiologic nadir. Other causes, and we'll go through other iatrogenic, meaning phlebotomy, just actual excessive blood removal for testing could definitely cause a role in a neonatal anemia. And then we have the pathophysiologic. We have different categories of blood loss, such as fetal. So these are things that take place really pretty much right before and during the labor and delivery process: fetal maternal hemorrhage, twin-to-twin transfusion. If a mother is a placenta previa and has bleeding, has an abruption and has bleeding, all things causing a loss of blood volume from the baby. Other things: increased destruction of red blood cells. The most common are the immune-mediated ABO and RH disease, which could be both chronic and acute or chronic loss of blood. Illness, any form of illness in both baby or mom can lead to a decrease and a more significant neonatal anemia. And nutrition, both in maternal nutrition and fetal nutrition, and we'll go into some of those details momentarily. So physiologic jaundice. So take a look back as to why this takes place. In fetal life, erythropoiesis is active. It's 3 to 5 times greater than we see in adults. They're constantly fetuses are making new red blood cells. However, at birth, you have a significant, almost 2 times increase in arterial oxygen saturation. As babies are disconnected from the placenta, those levels go up. And then there's the negative feedback, as we all know, on EPO production within the baby. So increased oxygen saturation and the negative, and then EPO production goes down. You have our reduced RBC lifespan, 60 to 90 days. And in addition, those RBCs are more prone to oxidative stress, hemolysis, and being taken out of circulation earlier. Fetal hemoglobin levels are higher. They're not as productive in oxygen delivery and other forms. And then there is some form for hemodilution, increase in blood volume following rapid weight gain. It's not clear exactly how much that plays a role, but these are the reasons that we would see a physiologic nadir both in preterm and in full-term infants. However, in preterm babies, there is some differences, and given the fact that our preterm babies overall are at increased risk for neurodevelopmental delays, they definitely play a much longer role. There's a correlation between gestational age and postnatal hemoglobin. The earlier you are, the lower your hemoglobin levels are going to be. So now our most significant, our most stressed, our most at-risk babies are starting from even lower levels. EPO production. During fetal life, during the pregnancy, fetal erythropoiesis takes place in the liver. At about 32 to 34 weeks gestation, it switches to the bone marrow. It switches to the bone marrow, and then we see that in full-term babies. However, in preterm babies, obviously, those who are definitely born 24, 26, 28 weeks of gestation, they're going to remain in the liver, and the liver is less responsive to hypoxia. So, and these take place even post-delivery while in the NICU. So as the need for more RBCs, as these babies have their lung issues and lung disease, their bodies are not making as many red blood cells and not trying to correct the anemia on their own, and therefore putting them even at risk for even more significant levels of anemia. Additionally, during the preterm life, there's accelerated clearance of EPO, or erythropoietin, and it puts them again not making as many RBCs and not being able to correct themselves in the face of both preterm and as well as in the face of increased, as we mentioned, destruction and other issues that cause the anemia to be more significant and severe. So the pathophysiologic causes. So We know that two of the more common ones are ABO and incompatibility and RH disease, always mixing of blood, and we see that antibodies from mom are passed on to the baby, causing red blood cells to be destroyed as they're confused for foreign invaders. Nutrition, there are nutrition deficiencies in premature babies, both caused from being premature and as well as from the inability sometimes to feed post-delivery. There's a significant increase in cyclical accretion of many vitamins in the last 2 months of pregnancy. Those babies who are premature do not have that period of time to get certain vitamins and minerals from mom. Babies are deficient in iron and B12 and other vitamins. This is not even including vitamin K, which we could talk about at a different point. But this is other things that put the babies at risk for just not being in a healthy state and not able to correct the anemia on their own. And then illness. Premature infants, as well as full-term infants, are at higher risk for illnesses. They're immunocompromised. Sepsis and other forms of illness, it could definitely play a role and put them at higher risk of basically decreased homeostasis and inability to correct the anemia on there as well. Other things which I'm really not going to go into so much about in this talk are hemoglobinopathies, spherocytosis, elliptocytosis, which are going to have increased levels of anemia. One thing I didn't mention I should have put on the slide is G6PD deficiency, where you get an increased anemia, and all those will apply as well. And iatrogenic, meaning, as we all know, as what we cause. So a newborn infant has a blood volume of approximately 80 mLs per kilo. So you can imagine in obviously a 2 kilo baby, that's 160 mLs, and a really small baby, 80. And sometimes in our babies who are born 500 to 600 grams, you're talking 40 to 50 mLs total of a blood volume. And especially in the 24 to 26 week range, significant number of blood draws that take place while they're under care. ELBW, extremely low birth weight, and VLBW, very low birth weight, are at increased risk. The sicker you are, the more tests people are looking to do. They include daily CBCs, basic metabolic profiles, bilirubin checks, blood, and which will withdraw. And one definite significant one is blood cultures. The amount that you need for a blood culture to have a true test is going to be a significant amount of blood, 1 to 2 mLs, to really be sure that you're having an adequate sample size. And to keep taking that out of a baby, 40, 50, who has a volume of 40 and 50 mLs, you can just imagine how you keep lowering and lowering the amount of available blood, and then the worsening already predetermined anemia. So how do we go back? Once we have a baby who is anemic, how do we go back to get them into a better state? So transfusion, and I know we're talking about managing without blood transfusion, but there's a couple of things we need to mention. First, and we'll go through a couple of cases and studies. There's no evidence-based guidelines as to when to transfuse a baby. Most of it, almost all of it, if you look through the literature, is based on expert opinion and dogma, anywhere from a range of having a hematocrit of 25 to 41%. And as I was once told by a surgeon, if there's more than one way to do something, none of them are right. When we have a situation where we know, well, we have a treatment, and this is the treatment that you should use, everybody follows it. You have appendicitis, almost always you're taking out the appendix. If you're having a range of hematocrits of when you would transfuse, and you're having different ways of doing it, it most likely indicates that there's no clear evidence one way or another, which is the correct path to choose. So I know we all spoke about bloodless medicine, and I'm a huge proponent, as Sherry Oswald said. I believe that is the safest way to treat all of our patients. I want to try to turn away and try to convince colleagues to turn away from transfusion. So this study, and this slide is about from a study from Guyenne in 2012, and they were looking at thresholds for transfusion. And I put this slide up there to illustrate a point. This is looking at, and this is from surveys, an international survey for transfusion practices. And what you can see, and on the x-axis you have certain aspects of where a patient is up to, whether how much oxygen support they are, if they're needed to have mechanical ventilation, and when you would transfuse based upon a threshold of hemoglobin. And what you can see is that there is, by these wide ranges, and when you're talking about a baby with a 50 to 60 ml blood volume, anything between 10, as again on the far left, 10 to 12 grams per deciliter, there is no consensus as to when the transfusion is needed. Perhaps there's some with mechanical ventilation, but you can see the wide ranging of views throughout the field of neonatology and dealing with neonatal anemia and when you would have to transfuse. So additionally, there was the ETNO trial in 2020, and they looked at a liberal versus restrictive transfusion threshold. And hopefully you can see the content, the slide over there on the right. The liberal use anything from from about less than 41 at birth to less than 34 at 21 days. If you're critically ill, to anywhere to less than, and for a restrictive view of less than 21 for a non-critical health state. And they took a look at different outcomes for these patients. The primary outcome was looking at death versus death and or severe neurodevelopmental delay at 24 months, utilizing these liberal and restrictive. And I'll show the results in the next slide, but the key finding here is that there's no difference. There was no difference in neurodevelopmental outcomes at 24 months. There was no difference in sepsis or other issues during their neonatal stay. There was no real clinical significance in ROP, retinopathy of prematurity. And what that to me shows is that using a restrictive threshold and allowing patients is definitely safe. Another study that was come out is called the TOP trial, the transfusion of prematures. This looked at ELBW. These are babies less than 1,000 grams. And again, higher or lower hemoglobin transfusion threshold. And as you see on the right, for primary outcome, death or neurodevelopmental impairment, there's no clinical significance between the two groups. And even going through all of them, even from severe vision, severe hearing, there was none. And I think the key message that we could take, and the key message that I try to give off to my colleagues at other institutions, that babies will tolerate lower hemoglobin hematocrit levels, lower levels of anemia than we give them credit for. I think it is very difficult to sit there and it's very difficult to sit there and watch that. But I think if you take a look at the outcomes, it is quite apparent. And because one thing is that in neonatology, I heard this many times in many different talks about topics, is neonatologists were very quick to adopt different treatments. It's because we feel that our babies are severe. We're trying to do everything we can to them. And honestly, not many things are tested on premature babies. But we're very slow to change. And so once you get into a practice of doing certain ways and treating babies in a certain potential and certain modalities, and you see good outcomes, it's very hard to change. So you get into a situation where you're transfusing at higher levels and you see outcomes, decent outcomes, it's hard to change and try to stay away from that. So clearly, transfusing babies at a certain point is not the best path. There's no, and in many ways, there's no reason to do it. But as I mentioned in the beginning, there are certain levels where they can't get past. And there are certain numbers where you have to say that a baby is at such risk for a neurodevelopmental delay that we would have to correct their anemia. But how do we choose a better path? How do we not get there? How do we not ever put ourselves in the point where we can say that we may be even having to talk about that? So I'll talk about quickly our experience at Englewood Hospital. First, as background, we're an 18-bed level, New Jersey here in the United States, level 3A neonatal ICU. And what that means is most of our patients have an expected delivery of 28 weeks or a birth weight of 1,000 grams. Are we taking care of all of ELBW babies at 24 weeks and 500 grams? No, we're not. However, we do not very frequently. That's a function of both some of our restrictions, but also the fact that prenatal and perinatology has succeeded, that the numbers of babies born at those ages and weights are dropping. But with what's called a regional perinatal center approval, which is like the highest tertiary care, we are allowed to keep babies who are smaller or born earlier. We have a very good relationship with our regional perinatal center, and they trust us, so we do keep a bunch of patients. As well as we are allowed to make exceptions for our official blood management program. We do have an official blood management program where where patients will be enrolled in at parents' request. However, the protocols and the policies and the thought processes within that program are what we use universally for all the babies in our NICU. There's really not much of a distinction in our minds, and there's really and not really done differently. However, to be able to keep some patients, we do sometimes enroll them. So certain things that we do, and I'll go into some detail in the next couple of slides. Early nutrition, very early, and we're seeing more and more. That's one of probably the key driver. The use of erythropoietin, the liberal use of erythropoietin, iron, making let me go back, and iron as well, making sure that we are using and maximizing the amount of iron that babies can tolerate to give them the building blocks and to give them the resources to try to on their own prevent a significant anemia that needs to be corrected. I'll definitely spend some time talking about erythropoietin in the world of neonatology. It is still, for some reason, controversial. Some people don't fully buy the evidence, but I'm going to go through some studies to show that I think that the use is safe and clearly effective in many patients. So we have a protocol at Englewood Hospital for the use of erythropoietin. We test all of our babies. I know I talk about phlebotomy, but we'll go back to that in a little bit. We do weekly hemoglobin, hematocrit, and reticulocyte counts to see how well they can do on their own and manage where we are in terms of their anemia. Our protocol is designed to reduce transfusion, both early transfusion and late transfusion. If we see a baby based upon prenatal factors, as mentioned before, ABO, RH, abruption, is going to be a risk for an early transfusion because as they're just starting from behind the 8 ball and that their levels to start with are so low, we'll start early. We'll take a look at our premature babies, our babies at those 28, 29, 30 weekers. And some of them, given their own physiologic and pathophysiologic nature, will be at risk for a late transfusion, as well as those babies with ABO incompatibility who have such a high, or RH disease, who have such a high level of hemolysis that they'd be at risk for a late transfusion. And we would utilize erythropoietin. We have excellent results. Hopefully we'll publish some of them soon. Our usual protocol is 300 units per kilo daily for a 10-day course. We have used other ones. We have used some for sometimes the patients are about to be discharged a high dose, but that is the course we usually use. We test on Mondays, so we would start it on a Monday. By the following Monday, we would begin to get results to see the first one that we would see is a reticulocyte count increase, hopefully going from 1% to 2% to the neighborhoods of 7, 10, even up to 12%. And then by the following Thursday, the course would be discontinued. But there have definitely been discussions in the neonatal literature about erythropoietin and about its use. So there was a Cochrane review in 2020 by Olson looking at early erythropoiesis stimulating agents in preterm or low birth weight infants. And what they found was that early administration of erythropoietin does not increase risk of death, does not increase risk of retinopathy of prematurity, which some of the earlier studies in the early 2010s had shown, and may decrease NEC, and it may decrease in neurodevelopmental outcome risk. Excuse me. It's important to show that these were some of the questions and issues that came up when the use of erythropoietin was first started in neonatology. And clearly, through meta-analysis, we're seeing that that may be incorrect. Additionally, there's been multiple trials showing safety and improvement. There was the Peanut trial in 2020, which looked at a high dose erythropoietin in 24 to 27 weekers. And while the results may not have shown, the results were somewhat controversial. They said that they did not show any change in neurodevelopmental outcome at 2 years of life. So some neonatologists took that to mean, well, if there shows no change in outcome, we shouldn't treat anybody with it. Others said, looking at maybe perhaps the endpoint of 2 years at 24 months, which is the classical use of looking at some neurodevelopmental outcomes in babies, that might not be the most appropriate time frame and endpoint to look at. And if you looked at 6 and 7 years, especially as children entered school, there were clearly improvements in neurodevelopmental outcomes for those patients treated with very high dose erythropoietin earlier. Olson, who also did a meta-analysis, there was a trial early on looking at morbidity and mortality as well. And they also showed, again, decreased IVH, intraventricular hemorrhage, and decreased NEC, necrotizing enterocolitis. Two key morbidity and mortality events that could take place in the NICU that would show that could cause not just anemia, but really those are the key ones that cause harmful and severe neurodevelopmental outcomes and delays. Iron. So babies are definitely a decreased iron. So we are big proponents of early use of iron, both in our PO feeding babies, giving them iron supplementation starting at 4 milligrams per kilo, going up to as high as 6 milligrams per kilo. We also use it in our TPN when we have babies who are on TPN. We'll use iron dextran to give them building blocks, and we definitely see safety and efficacy in our use of that. Like I said, we maximize it. In almost all babies, we maximize it at 4 to 6 milligrams per kilogram per day. And additionally, we don't tie it to EPO treatment. EPO treatment is a different tool in our armament for anemia, but we think that we really do need to provide for all babies and all of their building blocks the use of iron to help them correct the physiologic jaundice. And we continue it. It's not that we stop at a certain point. We send them home on it. We tell them that they need to be on it. We use it, and we make sure that our breastfeeding moms who may have a decreased risk are giving external forms of iron. When we have formula, if we have a formula mom, we use obviously iron fortified, and we keep going with the use of iron throughout the first year. Phlebotomy. So we talked about the use. So to reduce the risk from phlebotomy on our neonates, it has to be a joint project between neonatology and laboratory medicine. One thing I've always found during my career is that when you talk to other departments about small babies who need help, many people are very willing and to put in extra effort to make sure that they can help them. We use small aliquots as small as possible for our testing. And one thing we are definitely big on in our division is test for information you need. Don't keep looking for tests. Don't keep doing tests just to be sure. And don't order whole panels when you only need one. For example, if we're concerned about a calcium level, don't order a basic metabolic profile, order a specific calcium level. They can be done on smaller, as well as if you start looking for one issue and end up with another, you're going to be having more and more phlebotomy losses. Early nutrition. I mentioned that before. We start on day of life 0. We would like to get every baby feeding as early as possible, hopefully by day of life 1. Yes, there are times when babies aren't potentially ready, but if we can get human milk, we will definitely start as within hours after birth. We increase consistently, but not aggressively. We truly stick to about 20, especially with our VLBW patients, less than 1,500. We stick to about 20 to 25 mLs per kilo per day of enteral feedings. However, but we're consistent. We like to reduce NPO days. We don't want to keep taking a baby on and off. That is not good for nutrition, does not lead to a good nutrition profile. And what are NPO days? These are all these days that you get concerned that perhaps the feeding and the intolerance to feeding is a sign of something more systemic and more severe, and you hold off. So sometimes when we have rule out sepsis, especially when if a baby is showing signs of potentially being infected, people will make patients NPO. Obviously, if you are concerned for signs of necrotizing enterocolitis and the treatment is bowel rest, you would stop them. But it takes some it takes some being a little more liberal and not being super conservative to say, you know what, this baby may have a bloodstream infection and may have something else, may not be anything. We're going to start treatment. We're going to maybe do some tests, but we are not going to stop feeding. PDA treatment, this has been a real change throughout my career. It used to be, first of all, every PDA, patent ductus arteriosus, was treated in almost every neonate through the use of Indocin, which definitely causes, decreased blood flow to peripheral systems, including the gut. And you would make a baby NPO while you're on an Indocin treatment. And Indocin treatment can take 36 to 48 hours, of course. What we do now is, if we do need to, so first of all, a lot of more PDAs are not being treated. If a baby is showing signs of good perfusion and not allow what we call ductal steal, we will not even treat a PDA and we will keep watching. We may have a little bit of a fluid restriction, but then we can maximize calories within that fluid restriction. And if we do feel that we need to do a PDA treatment, what we will do is we'll hold our feedings, human milk or formula, at the point where they are. If they're, but not so, we will no longer increase over the next 36 to 48 hours, but we would definitely not make them NPO to allow for that nutrition and for the basic building blocks to be there. The other thing is feeding intolerance. Our babies sometimes have, especially those babies on respiratory support, show signs of spitting up, show signs of emesis. And instead of making a baby NPO for 24 hours, we'll hold the feeding, we'll put them on continuous feedings over a period of time, hopefully that we can continue that process. And what we found with early nutrition is that those are what make, I think what we're seeing is early nutrition and a great and positive nitrogen balance is probably what allows babies to tolerate lower levels of anemia and thrive and succeed. And then one other thing we look at with nutrition is human milk-based diets. And this, while human milk-based diets, and what we like to do is we would like to come to a point where an entire diet for a neonate is human milk-based. That will rely upon moms pumping and having breast milk, and sometimes we do use human milk banks. The unfortunate issue is that it is prohibitively expensive, and it can't always be done. But definitely, what we are doing too in our unit is for our most at-risk youth babies is putting them on a human milk-based diet, which is definitely easier to digest and will allow for less NPO. Phlebotomy. So like I said, as I keep saying, it's been underappreciated. And what we do is we minimize tests. We really hold off on giving tests and trying to hold off as much as possible on blood work. One thing we're able to work with our respiratory division, our laboratory medicine is using capillary blood gases with electrolytes. So those are sample size of 0.3 to 0.4. I apologize. 0.3 to 0.4 mLs of blood, and we're able to get both oxygen, pH, oxygen, carbon dioxide levels, and go ahead and get electrolytes and see where they are with their electrolytes. Cord blood, and a lot of what we use cord blood for now is for genetic testing. What we have found is that as the previous speaker mentioned, with pre-planning and knowing what needs to be done, we can get a lot of information off of the cord blood. And some of our genetic testing, those are the tests that are at 5 mLs, that require 5 to 7 mLs of blood. It's difficult to obtain, but really, if you take out 10 to 20% of a blood volume, it may definitely be almost impossible to really put them at risk of significant anemia. We also use H&H with retics. So we call them hemoglobin hematocrit with reticulocyte count. It's a smaller amount than a full CBC and a full panel, and is what we need. And we found that the information we get from that is definitely able to make decisions based upon who would need treatment. Again, the overlying question is for us in our unit with phlebotomy and over the course of other NICUs is we ask ourselves, why do we need this? What will change? Are we going to do anything with the results that we get? And if we're not, then we really don't order the tests anymore to minimize phlebotomy losses. Delayed cord clamping. So this is definitely a newer treatment. 30 to 60 seconds. I know I'm not going to, I don't want to step on anybody's toes from the previous talk. I'm going to leave it to the obstetricians is to decide exactly that this is what we see in some of our literature, 30 to 60 seconds of delayed cord clamping. And this is in all babies who are vigorous. So vigorous term and preterm infants. Obviously, if a baby is clearly in need of resuscitation, I think delayed cord clamping, while is definitely an option and not a requirement. But that's in term and preterm infants. And the studies are quite clear, something coming out of, I've seen in ACOG and other literature. Decreased transfusion, decreased necrotizing enterocolitis, decreased intraventricular hemorrhage. All those mean is decreased neurodevelopmental severe neurodevelopmental outcomes, as well as decreased amounts of transfusion-related injury, which is why we all know that bloodless is best, and also will lead to increased iron stores in patients, giving them again the building blocks to help correct their own anemia. One question does come up is jaundice, and while the evidence isn't as clear yet, there's definitely I hate the word, but trend that some of these patients are who have delayed cord clamping are more at risk for jaundice. However, if you work in a situation where you have a good bilirubin follow-up program, where you're able to follow babies and not lose them to treatment, that could be easily corrected with treatment of the very safe treatment with phototherapy lights. However, cord milking, and this is also from obstetrical literature and from neonatal literature, that isn't recommended. So really, to really milk the cord and get as much in as possible, it's probably not recommended. I think signs are showing it leads to increased intraventricular hemorrhage, and definitely in preterm infants should be avoided. Excuse me. This is all talking about what we can do as a healthcare team to reduce transfusion and practice bloodless medicine. However, a key part, and especially in the NICU, is relationships. And one thing that we have found is just talking to parents and treating them as equals. So while I said we want to treat all of our patients bloodless, and we basically give all the same care to all of our patients, we do have patients, obviously, whose beliefs and whose feelings will really feel strongly against the use of transfusion. And as I mentioned, there are certain points that we may have to, especially if severe hemorrhages and severe anemias. So the key point is parental discussion involvement always. And what we have always found is to listen to patients and to hear what they have to say and listen to parents. And then from our perspective, say we understand and we're going to work with you every step of the way and keep you updated. Everything goes smoothly. And we don't like threatening. We like to do everything in a positive manner. And that's what we're known for. And that is what we see. And that's why we get patients coming to our care. And I can't stress enough, really, is to understand and treat them as equals and not try to play this heavy-handed role as that we're the treatment team and we know better. It doesn't work in this, and it probably doesn't really work in any situation. So outcomes. So what have we seen any outcomes for allowing anemia, decreased transfusion? I mentioned before we have, but this is another study. This was published in 2020 by Kerpolani in the New England Journal. Looking at higher hemoglobin threshold and lower hemoglobin threshold, the two outcomes at discharge and at 2 years. And there is no difference. They use some of the cutoff that we mentioned earlier, 21, 24 hematocrits of 21 and 24. And what they're showing is that the use of a lower hemoglobin threshold and a decreased amount of transfusion and utilizing treatments such as epigen and iron and all the management strategies that we spoke about, they're getting the same exact results. Now, some people, the naysayers, the pessimists would say, well, if we're getting the same exact results, it's not helping, but it is helping because transfusion has its own risks and own issues. And I think as we change more and more units, and the optimists in us talk about, well, we're taking away issues and we're taking away risks. And they did not look at them. They did not look at some of the real transfusion risks, the transfusion-related lung injury and GI injuries and things like that. And as well as potentially even donor issues of using the donors, we're seeing the same exact results, and therefore we should change our practices. I want to quickly, I know, I mean, there may be another talk later this week, but I want to quickly just mention 2 specific cases that would just utilize and show how well we did. Cardiac surgery. So we don't have many, and we're not a cardiac, I don't say we're not a cardiac surgical center, but we have had a case in the past where we had a patient who was in our Bloodless program who was going to require cardiac surgery at 2 or 3 months of life, and working with our team and working with the parent and utilizing iron and bringing patient and putting them on erythropoietin courses and iron infusions, we were truly able to get the patient to a position where the hematocrit was over 40, which was the only place where the surgeon was willing to start taking into account to operate. I mean, they were willing to do it in a bloodless way as much as they can, but they were very concerned that to start off so low, how could they possibly do it? But working with the family and working with these treatments, we were able to do so. We were able to do that. And I mean, we've had a number of transfers. I put on here for my own notes, 28-week transfer. What this patient was, this was the first patient, I remember this. I'm not sure if Sherry remembers as well. This is the first patient we ever transferred from an outside institution to ours for a neonatal bloodless program. And it really goes through the entire gamut of what I spoke about. They were very upset that at their previous institution, that they weren't listening to them, and they were talking already from the beginning, lawyers and court actions, as they were really strongly opposed to receiving blood products. And they did their own research, and they came to find out about us and Bloodless. So the first thing we ever did with them was just sit down and just speak and ask and speak, hear their concerns, and explain our concerns, and say we will go through it, and we will talk it through, and we will not wait until, and we're not going to go through this legalized fighting amongst us. We were going to be a team together. The patient was transferred over very early in life, and through the use of all the modalities, especially erythropoietin, iron and the TPN, as well as PO iron, or enteral iron when the patient was up to it, and decreased amounts of blood draws. The patient never received a blood transfusion. They were told at their previous institution that there was a 95% chance that they would have to. They never had one here. We saw her for 2 years in follow-up program. She was thriving, doing great, like any other 2-year-old would be. And it's just a success story of what we see when we take using evidence-based medicine and working with families to really manage neonatal anemias without blood transfusions. I know I put in for questions. I believe we're doing it after the talk. And I thank you all for your time, and I hope this was helpful and informative.
Okay, thank you, Howard. That was really, really helpful, informative. And again, I think knowing the program and knowing your work, you're so modest, and your team, and how great the work has been. And you make it seem almost effortless, but I know it's not. And we have some questions, but I guess I would start just really briefly. I think you commented it a little bit in your talk, Howard, but because of the reputation of Englewood, et cetera, there's a lot of conversations that you have with colleagues, neonatal colleagues, and in other institutions. And you want to speak a little bit to how some of those conversations go, and how you, I think, have really been diplomatic, but also direct with the opportunities to do maybe a better job.
So I think this goes back to what I mentioned, that especially in neonatology, I find that people are hard to change, and until they're really put into the situation where they have to address it, it's hard to talk to them. So we get a lot of calls worldwide from colleagues, how to manage, can we manage? And I think it's 2 parts. One is it's similar talks like this, talking them through literature and evidence-based medicine, and to discuss what are their concerns and what are they feeling. And I know this is bloodless medicine, and obviously there are going to be times where we have to say, you might be right. But more often than not, those are clear-cut questions. We're not getting those. We're getting the questions about the 28-weeker who's, how low can I allow their hematocrit to go? And I think the first thing is we have to ask them, and we do this, and we talk them through over not just one conversation, but definitely over the course of their neonate stay, is what are you worried about? What are you concerned about? And a lot of times the answer comes up as, well, we've just never done it. I can't look at numbers that low. Like things you're just scared because you want to because they're so fragile and so small, and you want to put them in the best possible care. So we talk about the use of erythropoietin. We share them our protocols. We tell them to feed and give nutrition and really talk. I think it's almost as they need a colleague to talk them through questions that they've never encountered, and the unknown of what they're going to face. Not today, but like, oh, it's the hematocrite's 27 today. Well, what's it going to be in 2 weeks? I said, well, and we explained to them, well, if there's really significant anemia that's really causing increased morbidity and mortality, you're going to see signs earlier before you get to that point of really significant morbidity and mortality. You may have a patient slightly more oxygen requirement, slightly more heart rate, signs of high output failure. It's not going to be one day they're fine and the next day they're on an oscillator again. So you have time to watch and see. We tell them that, and we talk to them about how to talk to parents and go through it like that. Obviously, if it's just a situation where it's in our local area, we will offer very politically and very calmly to transfer, and not to step on anybody's toes, but perhaps it's better for everybody involved. But what we really like to do is just have the conversation going, and then show them some of our cases and our information as to where we've had success.
Thank you, Howard. And again, on behalf of the audience and patients that are not in the audience right now, but thank you for making yourself available 24 hours a day, you and your team, for decades at this point, to really assist these families and your colleagues in this really challenging area. Thank you. I know that Dr. Lim had a comment, Carol Lim from Malaysia, for our speakers, or a question. Dr. Lim, are you on? Okay. Dr. Lim, if you're talking, you're muted. So, okay, I guess we'll, are we on? No, don't see her coming on. Okay. So I guess we'll move on to just another question, and we just have a few minutes. So we have a comment from one of our colleagues for you, I guess, for Dr. Ekanem in Canada. And she makes the comment that she noticed that in cesarean section, the anesthesiologist will give half a dose, talking about uterotonics for fear of hypotension. So she's making the point that atonia is also bad for hypertension. So do you have any comments on that? Any hesitation or concerns that as you interact with colleagues in anesthesiology where they have concerns about use of these agents and concerns about hypotension?
Yes, thank you very much. It is important that one of the major side effects of oxytocin in particular is hypotension. That is why it is given slowly. Most times, 5 milligrams is given slowly as IV. But if it is a vaginal delivery, it is given as IM, so that the onset of action will not be as fast as that of IV. That's why I say most times, many people would prefer to use carbamazepine, because the onset is slowly and the action is sustained.
Thank you. Dr. Burns, did you have a comment on that?
Yes, actually, just I was going to get back to Dr. Mazin and make a few comments. First off, I think you're dovetailing off what we were talking about with Dr. Ekanem's presentation, that this coordination of care with patient-centered approaches, and in terms of both the obstetric as well as your neonatal patients, we're talking about family, right? We're talking about very nervous, very concerned parents, and any of us in the audience that have been parents, or for those of us women that have delivered our babies, we know how we feel and how proprietary we are about the care that we receive, especially for our kids. So I want to thank you for really commenting on that. And then also you made that comment about communication with the laboratory. So as a pathologist, I applaud you for that, because that was always something we wanted to do. And all of our speakers throughout these sessions have talked about that coordination with the lab. The lab is always willing to be able to provide you the most specific information you need with the least amount of blood. So I encourage everyone to talk to their laboratories. I put in the chat box, by the way, there was a just hot off the press in Transfusion Journal, a cord blood review and how to test off of cord blood, what information you can get and what you can't. And so that might be helpful for any conversations that you're having amongst your neonatologists in your laboratory. And then I'll just throw out a question to you all, both of you. We know in the United States, we've been having a formula shortage for babies. And those problems, how are those affecting your institutions, both in the United States as well as in other countries? I'd be very interested to know, because that affects that nutrition of those babies.
So in the hospital itself at the moment, I think we are okay. And that's, I think that's an unfortunate statement to make in 2022, that in a country like the United States, we are okay. We have through some investing by the hospital and our health system, switched over in our patients probably less than 34 weeks to a human milk-based diet, utilizing both obviously express breast milk from parents as well as human milk human milk banks that are located. However, we are definitely concerned for those who are at risk for late transfusions, at risk for late anemia, who are choosing to use formula feeding as to the availability of formula. So we are definitely trying to encourage more breastfeeding. We're trying to get more resources to give out breast pumps to those mothers who may have used that as a barrier to breastfeeding. And we are just honestly, day by day, honestly, I was getting texts from some of my colleagues while I was speaking about some other issues coming up and just utilizing different formulas and different methods, but obviously encouraging parents to stay off of social media. Please don't try to make your own formula. Please don't try to use any of these goat milk form of things you may come up. And I know, and now I have to wear different hats here as a neonatologist, as a board certified physician as well, but as well as someone in the community, turning almost a blind eye, like sharing of breast milk and things like that, and between families, and just hopeful that this will correct itself in the next couple of weeks. But definitely trying to give more encouragement for breastfeeding and more encouragement for express breast milk.
Thank you so much for the comment. I think that based on time, we have to take a short time now to listen to our colleagues from HemoCue, and then we will actually, I'm not sure who can continue to stay with us. If you can, I know there's a couple more questions. When they're finished, after about 15 minutes, we can pick up for a few more minutes on Q&A if our speakers have to leave or anybody, we understand. But with that, I apologize for that, but we have a little timing shuffling to do. So Yvette Bunch, can I introduce you to introduce our guests? Thank you.
So Pierre Costable and I have had sort of a business relationship since the SABA meeting in Houston, Texas. A little bit about Pierre. He lives in South Africa, but he's had 10 years experience in the medical diagnostic field. He also has a strong pharmaceutical background. He does have his master's degree, but he is also now taking a business management course from Harvard University. The neat thing about Pierre is he has an international knowledge that is very helpful. And we have used HemoCue as a point of care. We've been talking about taking, what we considered once bloodletting. We need to decrease that, and HemoCue is certainly a wonderful tool that you can use as the point of care. So I'll turn it over to our speaker now. Pierre, are you there? Yes.
Yes, Yvette. Hi. Thank you very much. Good to see you. Very good to see you indeed. Thank you very much for the introduction. And so I'm going to share my screen to do my presentation. here we go. So can you see my screen, Yvette and everyone? Yeah. All right. Okay. So thank you very much. So I'm going to discuss briefly today about anemia as a health priority in maternal and child health. So first of all, I would like to do a bit of introduction about HemoCue, and then we will see anemia in maternal and child health. I will present you the health standard solution that we have presently at HemoCue. And I will touch a few words about the use of HemoCue systems. I will also present to finish the new HB801 system that we have. So just a few words about HemoCue for the people who don't know us. HemoCue is a Swedish company founded more than 30 years ago, actually 40 years ago. It's fast. We have a global presence worldwide, and a lot of people are using our product, and we estimate that about 4 HemoCue tests are performed every second in the world. So at the time speaking, a lot of tests of HemoCue in the industry. So what do we do?
I'm
Yes?
sorry, Pierre, are you advancing your slides? Because we're not seeing that.
Oh, okay. Yes, I am. So I don't know why it is not showing.
Yeah, please click on slideshow.
Slideshow, sorry.
On the top bar, you'll want to click on slideshow, presentations view.
Okay.
I don't know if you had already clicked on that.
I'm just clicked on it. Is that working like that? No. Okay, so maybe let me stop sharing and share again.
Okay.
Like this. No. Sorry, I don't use much Zoom. I use Microsoft Teams.
That's
a
okay.
lot.
Yeah, we can see all the slides now. So if you select one.
All right, okay. Is that good like this?
Yes,
Oh, okay,
It is
perfect.
better.
it's
Not
better.
full screen.
Right.
Yeah, full screen, please.
How do I do full screen? No. I'm sorry, I don't know why it doesn't go full screen.
Oh, no problem. It's good. We can see all the slides now. Maybe under display settings on the top next to show taskbar in the middle.
Yes. Okay, so presenter, duplicate slideshow. No.
Go ahead and click on the first one. Swap presenter view and slideshow. There you go. Now we can see them. Oh, no.
Okay, no.
It.
Oh, not anymore. Okay, sorry. Okay, let me try again. Okay. Okay, now it should be working, I guess.
There we go. We can see it clearly. Thank you.
Yes. Okay, great. All right. So we are. What do we do in a nutshell? To finish the introduction, we have a strong portfolio in hemoglobin and anemia on the left. We do diabetes as well, and we do white blood cells. Okay, infections, everything at the point of care. So very fast results, portable machines, equivalent to the laboratory quality. Okay. So decentralization of the lab for HemoCue. So we have different hemoglobin systems. Probably among the people that are attending today the conference, I'm sure you've seen some of these models for different applications. So I will go a bit faster on this because we have a limited amount of time. So what we have that is very interesting, and I'm gonna play you this video, is something for maternal and child health. So I'm going to play this video. Okay, so for some reason, the video is not working. Okay, so that is not a problem. So I will just describe it in a few words. So what HemoCue does is that we know that a lot of pregnant women and women of reproductive age have anemia. It causes fatigue and lethargy. It impairs the health and quality of the mothers. It increases the risk of adverse maternal and neonatal outcomes. And it can have a negative impact on the development and learning of the children. So it's a lot of issues actually, and side issues and related challenges with the pregnant women, the mothers, and the children. So we have developed a lot of solutions around that. So one of them is named Health Trender, and it's something that enables to monitor the effect of certain screening programs. So we have an example in India, where amongst a percentage of the population, they will give, for example, nutrients, additional food complements, and they will try to monitor the level of hemoglobin amongst this population. So, for example, we can choose the woman and the men, for example. We can dissociate between regions as well, and we can see if a certain program is effective or not. So it's a very interesting solution that is cloud-based solution that is using Bluetooth devices that we can transfer to the phone and to the clouds, and we can monitor it anywhere in the world. So that's a very interesting thing that we have at the moment. Just a few words to come back more about operative anemia, because it's more part of the subject today. We do have a lot of advantages of using the HemoCue hemoglobin system for pre-operative anemia, perioperative, and post-operative. Okay, so I have to go a bit fast because we have a limited amount of time, as I discussed with Dr. Nat. So if I continue to come on the use of HemoCue analyzer, some important reminders is especially about these steps. Okay, so once, for example, on a capillary sample, the blood is collected into the microcuvettes by capillarity, we need to be very mindful that there is no air bubbles happening like here, that is not completely filled, and an air bubble here, as we can see that I'm showing with my pointer, with my mouse. And then another one that is important to know is that it's important to wipe the both sides of the microcuvettes before inserting it into the analyzer. Because if this step is not done, what can happen after thousands and thousands of tests is that the blood can go inside the machine and start to coagulate on the optical lens. And then it will need some maintenance, of course. So it's just two important reminders and steps when you perform a test with HemoCue machines. About the cleaning, very easy, everything is explained into the manual, so I go a bit faster on this. What about our new HB801 system? So minimum volume, maximum trust. So we are the worldwide leader into hemoglobin testing. Okay, we were the pioneer, HemoCue in Sweden, as I say, about 40 years ago. And we have developed this new instrument, HB801. So I have a video also that is available on YouTube. I can't play it now because it looks like it's not working for some reasons. But there is a lot of information available on the web, on the HemoCue.com website or for your region as well. I will just describe a few features. So it gives you a lab accurate results in less than 1 second. So it's instant now. It's designed for challenging climate and conditions. So it's tropicalized. If it's very hot and humid temperature, this machine can resist to that. So we use it a lot in Africa, for example. It has flexible power supply options. It can be either AA batteries, it can be to plug it with a normal electrical system, and it has rechargeable batteries as well. It's very easy to clean and maintain. The microcuvette has been enhanced and improved for use for left-handed, right-handed, how to insert it, and so on. It's got a very large memory capacity. It's got flexible connectivity options using Bluetooth or USB cable. So transfer of data is very, very good with that machine now. It's got intuitive symbols to explain what's happening, the results, if there is a cleaning necessary. And it displays hemoglobin and hematocrit value as an option for the people who would like to see the hematocrit. So thank you. I've been going a bit fast without playing the videos, but thank you very much for listening. And I'm here. I listen to any comments or questions. You are welcome.
Thank you so much, Pierre, for that informative discussion. Are we going to open up to more questions now, Sherry?
Yeah, I'll turn it. Yeah, thank you. Thank you so much, Yvette and Pierre, for that. And I appreciate our speakers staying on. I know, Howard, you might have to jump off. So I'll just point a couple more questions at you. And then perhaps Dr. Ekanem, you're able to stay with us for the next 15 minutes, I hope, until the end of the session. Okay. So in case you have to go, Howard, I know that you already answered this electronically, but I think it merits some conversation. I'll tie a couple questions together that were about both use of EPO and iron as complementary medications, and also concerns that, sort of we hear not just in the neonatal world, but also in the adult consistently across the PBM space is sepsis and iron. So if you can kind of comment on both of those things.
I'll take the second one first. I think
Sure.
I've definitely heard of that, but I really never seen much in terms of adverse outcomes from utilizing iron in the time of sepsis. It is definitely harder if you are using an enteral form of iron and the patient has to become NPO, but that's why we talk about using it, iron dextran. We use iron dextran through TPN. I've looked at the literature. I've really haven't seen much that's weighing me to say that it's a problem. And I think it's a time that you would have to go ahead and use iron, and I think it's safe to do so with no adverse outcomes. The first question about tagging EPO and iron, maybe it wasn't a little bit clear. We don't use EPO on every baby. We use it on babies who are at risk for anemia levels that require transfusion. So our part of our protocol is if you put a patient on EPO, they go on iron, they go on folic acid, all the building blocks necessary for good manifestation and good utilization of the EPO. For other levels of even just physiologic anemia or more milder, we put everybody on iron. So that's what we do here in the NICU. I think that's really recommended by the AAP, is that all babies are on an iron fortified diet, either through formula or through breast milk. So EPO is tied to iron in the sense that if you're giving EPO without giving iron or folic, you're not giving them the building blocks to utilize it. But we do obviously use iron independently for almost for every one of our patients.
Great, thank you, Howard. And I see a question. I'm trying to understand it if I'm getting it clearly. It didn't come in the Q&A in the chat, but it's a question about sickle cell anemia, and of course, this a common issue, right, throughout many parts of the world. Did you want to have any comments on?
I mean, I think it's a little bit out of my jurisdiction in the sense of, I think for patients who are at risk for sickle cell or maybe diagnosed with sickle cell in the NICU, we do treat it the same way. For those who are older, I think I would have to leave that to the hematologist. It's not something I really feel confident speaking about. But for those in the neonatal period with sickle cell, sickle cell does play a role sometimes in their anemia, and it's the same point is don't let them get to the points where you were concerned. Don't go down that pathway. Start early, and you'll have success.
Great, thank you so much, Howard. So last call, Dr. Mazin might have to step away. So if you have anybody other pressing questions, please put them into the Q&A. If needed, or any of our other panelists.
I think I'm okay. I think I got somebody to handle it. I can figure out.
All right, thank you. So I'll direct a question, to Dr. Ekanem, if Professor Ekanem, if I could. There was a question regarding your mentioning of dopamine as an agent in your postpartum hemorrhage protocol. Could you talk about the mechanism of action? And you can see I think the question here, the advised line of care in the event of a woman with postpartum hemorrhage with class 4 hemorrhage.
Yes, thank you very much. Dopamine is anticholinergic. It's not used routinely. It's when we have a patient with anuria, that is making urine poor, and we need to improve the urine output. That is when we use dopamine. It's not used commonly. Dopamine acts as an anticholinergic agent, which improves the circulation of blood around the area. And with that, the urinary output is improved. That's essentially how it acts. But it's not everyday thing. It's not used as a routine medication in the management of cases like that. The other question was what?
Sorry, the other question was related to the line of care in the event of a postpartum hemorrhage with class 4 hemorrhage. I think you reviewed it in your slide, but if you want to review that.
Yes, yeah. I remember class 4 hemorrhage is the most severe form of OH. And such patients are usually admitted into high intensive care unit, where the highest form of care is instituted. It's not the one that we use in the routine. Every facility, every professional is invited to act on each part of in his own area to improve the outcome of the patient. The type 4, like I mentioned, is if in those days you want to provide blood, is transfusion of a massive transfusion of blood. But here, with what we have, we can also do that. Sometimes hyperbaric oxygen is given. The patient is put in oxygen bath, where oxygen is supplied in a continuous basis. And other professionals will act based on the pathology that occurs. It's not, most times, if the treatment is done early enough and most of the protocol is followed, rarely will you get to the point that you have stage 4 OH.
Great, thank you. Thank you so much for that answer, Professor. Appreciate that. Yvette, did you have something? I see that you wanted to jump in with a comment on the Q&A.
Dr. Mazin, my computer went down through part of your presentation, and you may have answered this. Is there a particular time that erythropoietin is more effective? And is there a particular formulation that is in your protocol that you prefer to use?
So I think the time of being more effective, I think it's not great always when you're really trying to go from the lowest potential levels. Like when we talk about hematocrits 21 to 24%, the response time is given what needs to be done. It is the results are not always what we want to see. We find that at about 2 to 3 weeks of life is, I would say probably someone neighborhood about 2 to 3 weeks of life, 31, 32 weeks corrected based on who we see. That's a real good point to see excellent efficacy in terms of prevention. In terms of formulation, unfortunately, I think a lot of that is based upon hospital contracts, and we do talk with them and about what we using Apogee. We're using a different, I think, Retocrit now. Nothing really seems to be any difference between the two. We don't seem to have much change in the formulation that we use.
Thank you, Howard, and thanks, Yvette. And Jamila, Dr. Sather is on from Malaysia.
Yes,
Howard,
I have a question.
Yeah, a question.
Hi. I have a question for Dr. Mazin. Yes. Do you use iron intravenously in your neonates?
Usually we would utilize it as an addition to our TPNs. We would not use, we don't usually routinely use it as a standalone medication or infusion, a standalone vitamin intravenously. It's only usually used intravenously for those who are not yet either feeding or not tolerating feeds. We want to get it started going earlier.
Okay, thank you.
Thanks, Jamila. And another question, Dr. Mazin, it came on the Q&A about parenteral feeding for extremely low birth weight babies. What challenges you encounter with NG, nasogastric tube feeding, and how soon do you commence?
So these are the people who we commence day of life 1, day of life 0, day of life 1. We will start off very slowly. We're talking, I like to use, I would say 20 mLs per kilo per day, but usually when we start, it's probably 1 to 2 mLs every 3 hours, just to really do some gut priming and to start feeding. But we do start feeding as early as possible. Especially, and it's almost like inversely proportional. The earlier you are, the earlier we want to start feeding. The later you are, for some of our patients who we see 30, almost close to full term with some of this mild respiratory distress, we may hold off, but the younger you are, the earlier we want to start feeding. And we would do it, obviously, NG, OG feeding.
Great. Thank you. I'll give another question. We have a couple more minutes back to Professor Ekanem. I see in the chat, once cavitocin is used, does it allow subsequent use of oxytocin? So the question directed for you.
Can you come again? I've lost the question.
The question reads, once cavitocin is used, does it allow subsequent use of oxytocin?
The mechanism of action and everything is almost the same. It's just that cavitocin is more heat rebel. That is sustained, is given in, it tolerates heat compared to oxytocin. And the action is more delayed. The onset of action is delayed, but it's more sustained. So there's no point mixing the two together. That's the answer.
Great. Thank you for that. I think one back to you, Howard. What non-blood management options are available in cases of severe neonatal hyperbilirubinemias that may require exchange blood transfusion?
So unfortunately, we have not come across anything yet that would be in that situation. I think this goes back to what I mentioned about having a good bilirubin follow-up. So I mean, in terms of not letting kids get past, not letting kids fall through the cracks. We test, obviously, we get a blood. So, I mean, there's the more common ones, such as ABO incompatibility, where we are getting blood types at birth. We have a protocol where we are doing bilirubin levels, hematocrit level, hemoglobin hematocrit reticulocyte levels at 6 hours of life. We're quick to put on to phototherapy to try to prevent getting to exchange transfusion. We talk heavily with our colleagues in terms of those who have been RH isoimmunized. We're working with ROGAM and knowing kids and sampling even off of cord blood or even during CVS type sampling to know who would be at risk ahead of time. But if you do get to the point where it really needs an exchange transfusion, there's not very really good modalities out there to change that with having good results.
Thank you. So I'm going to actually direct this at both of our speakers. You both had some comments, obviously, from different perspectives on cord clamping and delayed cord clamping. So we have one question. Can we talk a little bit more about that? Someone's asking for clarification. So I thought maybe if you could both, I know you both talked about it, but comment again on how that fits into each of your perspectives. You want to start, Professor Ekanem? I know you reviewed it, but maybe you can mention one more time your perspective on delayed clamping.
Well, yeah, delayed clamping, just like the pediatrician had mentioned. Like I said, is part of the management of preventive management of OH in a woman that is delivering vaginally, even cesarean section. It is noted that, particularly in preterm babies, delay in clamping the cord may give some blood to the fetus, to the baby, as it is, as opposed to early clamping. And it is noted that early clamping may delay the contraction of the uterus because the blood that is coming out from the uterus to the baby may delay the uterine contraction. Sometimes when the blood is coming out, you accelerate the contraction of the uterus, and so I said help in the detachment of the placenta and prevent bleeding. So essentially that is what it is. Before now, cord was clamped. Immediately the baby is delivered, you clamp the cord, then try to do control contraction to remove the baby. But now, most studies have not shown any usefulness over delay cord clamping and early cord clamping. But having said that, each case is taken on its own merit. There may be cases that you need to clamp the cord and quickly remove the placenta, and also the one you may delay. Sometimes there is a delayed delivery of the placenta itself, or spontaneous delivery of the placenta. Because recent times, it has not been shown that active management in terms of control contraction over delay management of the removal of the placenta has shown any significant difference. So that's that.
Thank you.
People, these days, people tend toward delaying cord clamping.
Thank you. Howard, last comment, because we're almost out of time, but.
Sure, no, I definitely agree with Professor Ekanem that most places are, it's becoming standard of care to do delayed cord clamping. From my perspective, the question usually comes up with preterm infants, do I need, from the obstetricians, is do I need to, they want to do it because they know the benefits both for the baby as well, and I'm even learning now for the mother as well, and they ask me if we need the baby immediately or do we have 30 to 60 seconds, and it's almost always you have the 30 to 60 seconds. It's more in the situations where it's a very depressed baby who need immediate resuscitation. But before that, delayed cord clamping is excellent. It helps prevent against anemia in the neonatal period.
Okay, fantastic. Thank you again. We're out of time here. Thank you so much, Professor Ekanem, Dr. Mazin. Really a critically important area to discuss, and one that still remains challenging. Some of this content, of course, in the future will be available on YouTube. We've had a lot of folks ask, and presuming perhaps that you might make yourself available by email for additional questions from any of our attendees. Of course. Okay. Thank you, Dr. Ekanem. So with that, I'll hand it back over to Dr. Usoro, my colleague and friend, for a preview of tomorrow's program and the rest of the week. Thank you, everybody.
Thank you very much, Sherry, and a big thank you to our speakers of today and panelists, and of course the audience, without whom we wouldn't even be here. Thank you very much, everyone. And for tomorrow, we are going to have yet another interesting session. There's going to be a CPD Symposium entitled Blood Conservation Saves Lives, because prior to this time, it was blood donation or blood transfusion saves lives. But the paradigm shift is that blood conservation or avoidance of transfusion saves lives. So the first talk will be on the topic, optimizing the hematocrit in obstetrics the rational way. We'll have a very senior speaker from Malaysia there, and then oral iron therapy with ups and downs, but still effective. We have a sister bloodless medicine and surgery group about 300 kilometers from where I am, and the speaker will be from the Assistant Director of Pharmaceutical Services in the Federal Medical Center in Owerri. Third topic, blood conservation in pediatric surgery, to be delivered by an eminent professor of orthopedic surgery. In fact, it is of pediatric orthopedic surgery and chief of pediatric orthopedics, Hasbro Children's Hospital in the US, a very committed and avid bloodless surgeon. And finally, we'll of course have an industry presentation. So once again, thank you everybody for being here. And we look forward to seeing you again tomorrow. Thank you.